Okay, Elior, what do you think of this case?
Yeah, we have 21-year-old college football player elbow dislocation. Um, yeah, looking at the lateral elbow at the radiocapitellar ligament, looks like there's a full thickness tear at the proximal attachment.
Look over here, let me get a little bit of edema in the flexor muscles.
Mm-hmm.
What do you see here?
Mm, yeah, that ligament there, is that the radial collateral or is that a
Communis portion
of the communis tendon?
of extensor.
Looks like a tendon,
Yeah, yeah, that's the
conjoint tendon.
communis common extensor tendon. We have edema over here. We want to look carefully at the ulnar collateral ligament. And then there are sagittal images.
Mm. Okay, we see an effusion.
Yeah.
I'm not sure what else.
Okay. So we see a diffusion. We can't really follow the lateral ulnar collateral ligament here very well when we look for it. So there are a bunch of injuries, and as you would expect, if you have a knee dislocation, you're going to tear pretty much all of the surrounding ligaments.
It depends on which way it dislocates.
Right. Yeah.
All right, so looking at the lateral elbow, looks like there's a high-grade tear, common extensor and proximal lateral intercollateral ligament.
Yeah. So this was more of an acute injury in this particular patient. This was a 0.2 Tesla scan. Okay.
So this is an all-terrain vehicle accident.
Yeah, this is from Colorado.
mm,
Okay, so here we just see a lot of edema within the soft tissues.
uh-huh.
Over here, I'd certainly be concerned that we may have some injury to the annular ligament. We need to look at some of the other images.
Mhm.
What do you think about these images?
Um, there's like a dislocation
Okay.
of the elbow.
So here's the olecranon here. There's the olecranon fossa, and we can see that the distal humerus is dislocated anteriorly. We can see that there's a lot of fluid around. And as you can guess here, really the capsule and really all of the stabilizing ligaments are torn in order to have this kind of dislocation. Right? Oh, Robert. Robert?
So we have a 12-year-old male evaluating for OCD.
But we can't hear you very well, Robert.
1 second.
Do you know where the mic is on that computer?
Can you hear me now?
I cannot hear Robert either.
Can you hear me?
You know, we'll skip you, Robert, unless you can figure out how to turn your mic up.
All right, 12-year-old male, evaluate for an osteochondral defect. Yeah, so on the right image, we see a bone fragment off the medial epicondyle.
Medial?
Oh, yeah, the lateral, sorry.
I think it's the other T1 waved image. It's much, we can see the details much better on the PD facet image.
Hmm.
This was an acute avulsion fracture.
All right, so it looks like there has been a repair of the common extensor.
So here's a postoperative. So, this is often called lateral epicondylitis, which is a misnomer that I think is dangerous. Uh, uh, 90% of these injuries are strictly tears of the tendon and don't really involve the bone. 10% you can see some bone edema, and rarely you can get an avulsion fracture like this, but this is very uncommon, typically in the very younger individuals. So it's actually a tear. Often it's chronic in middle-aged individuals where it's a very common, probably the most common symptomatic problem that we see of the elbow. It typically occurs with first degenerative disease from chronic repetitive use, and middle-aged individuals, it then goes on to partial tear and symptoms of it. And it's so it's not inflammatory. It's not an inflammatory lesion. It's a tear, like we've been talking about a lot of lesions. This is similar to the typical pathology that we see in the musculoskeletal system. In prior days, it produced pain and tenderness and occasional redness overlying it, which were the signs of inflammatory disease, but it doesn't have the biochemistry or the pathophysiology of inflammatory disease. It's really a tear, and therefore really should be treated like a tear. And in this particular case, you can see that they actually repaired it surgically. Natalia.
Well, there's a lot of edema.
Yeah.
On
So
the-
here we can see the radius. This is the lateral side. We can see all this fluid out here. And then what are these dark structures here? Okay, so this is susceptibility artifact. So this patient had prior surgery, and this was a tear of the surgical construct. And this is a large defect involving the lateral capsule here and the radiocollateral ligament, the common extensor tendon, and this case also involved the lateral ulnar collateral ligament as well.
Three-year-old, pain and swelling. We have radiographs. Let's see. Is there displacement of the posterior fat pad on the lateral? Maybe an effusion. I mean, I'm not, yeah, pretty negative, I think.
How about an MR?
Sure. Okay. The image on the left, I see edema in the radial neck and the sagittal, yeah, radial head and capitellum. Okay, so this dark structure there. Mhm.
This is the kid.
Okay.
So what kind of things would you think about in the kid?
I mean, we think about, with regards to a tear, like an avulsion injury, but
Yeah.
I don't know.
So this is, these can be subtle and easily missed if you don't have a diagnosis. But this is a toddler, and yanking on the arm is a common injury for toddlers. And this is Nursemaid's elbow, which is really a kind of a subluxation of the radial head, and with often an injury to the annular ligament here. And here you pull on it, so it typically distracts the radial head here. This is normal. And then often the annular ligament can flop over the radial head, and you're left with the annular ligament partially interspaced in here in the joint space. John?
Nursemaid, I'm sorry, nursemaid's elbow.
Yes. Do you want to say anything about it?
It was described by Blount. He wrote a book on pediatric fractures.
Uh-huh. Okay. All right. So let's now move on to the medial side, which is much less common than lateral side pathology in the general population, but much more common in the athletic population. So now we're talking more about athletic type injuries. And if you look at the medial side anatomy, here's the anterior band of the ulnar collateral ligament, which we'll be talking quite a bit about. Here's the posterior band of the ulnar collateral ligament, which is much less commonly injured. And then the transverse or oblique band, which goes from bone to bone, and I don't think is a very important structure here for functional reasons. And then if we look at the tendon attachment, the most proximal big one here is the pronator teres attachment. And then we get the flexor digitorum superficialis, which is more posterior. So athletic injuries causing strains or tears in these two muscles are pretty common. And anteriorly, it's the pronator teres. And then the straight medial, a little bit posterior, is flexor digitorum superficialis. And then this is just another diagram, the biceps coming down here, and here's the anterior band of the ulnar collateral ligament, which we'll be talking a lot about, the posterior band, and the oblique or transverse band. And on MR scan, this is typically what it looks like. Now the anterior band of the ulnar collateral ligament tends to run a little bit oblique to the coronal plane. So often if you have a true coronal, you'll see the distal part and the one cut. The next cut more posteriorly, you'll often then see the more proximal component. The proximal component has more vascularity to it. The distal component tends to be fairly avascular, and then it inserts here on the sublime tubercle. The reason I say that is you can sometimes see thickening and some increased signal intensity within the proximal component, which has to do with slightly different tissues within the proximal component. So ulnar collateral ligament injuries, they can involve the sublime tubercle, the bone itself. They can be proximal tears, which is the most common location where it tears really at the bone-tendon interface proximally from the medial epicondyle of the humerus. You're going to have mid-substance tears or distal tears near the sublime tubercle. And the common cause of these are in overhead throwing athletes. And as we can see here, in the throwing mechanism, when you cock the arm back, you get traction on the kind of medial aspect of the elbow, impaction on the lateral aspect, and this can produce strain injuries of the ulnar collateral ligament and sometimes bony impaction injuries on the lateral side. Jason, you next?
Yeah.
Okay.
Valgus injury. So looks like we have a trabecular injury to the lateral epicondyle,
Okay.
and like there's some increased signal. Yeah, right at the medial epicondyle attachment of the UCL.
So it's a valgus injury. This happened not to be in an athlete. This was actually a traumatic injury to the elbow, but here we can see that kind of mechanism where you have a traction injury here and a tear of the ulnar collateral ligament and impaction here on the lateral side. With athletic injuries, it tends not to be a single acute event like in this case, but chronic repetitive trauma where you end up usually traction injuries of the ulnar collateral ligament, but sometimes you can have when that pops, you can get displacement of the bones and an impaction injury on the lateral side. Okay. Natalia.
15-year-old male basal picture, rule out UCL tear versus stress reaction.
Okay, so what's this structure right here?
The ulnar collateral ligament.
Okay, that's the ulnar collateral ligament. It's
Uh-huh.
through blind tubercle.
Mm-hmm.
And here on the T1 weighted image, it looks pretty nice. We can see a little fat pad in here that we're going to be talking more about.
Mm-hmm.
You can see it's intact on the T1 weighted image. If we go to the PD fat set image, what do you see?
Like some edema.
Okay, yeah. So there's a little bit of edema here of the muscle,
Uh-huh.
maybe a little bit deep in the ulnar collateral ligament. And then here on the PD fat set image, we can see a little bit of increased signal intensity, maybe a little thickening of the proximal ulnar collateral ligament.
Mm-hmm.
And then I always like to look at the sagittal images through this area. And here we can see this is the medial epicondyle, and this is the area of the attachment of the ulnar collateral ligament, and we can see some edema in through here.
Mm-hmm.
So this is a grade 1 sprain. The proximal ulnar collateral ligament with a little bit of edema around it. Usually these are treated conservatively because, as I said, this part is vascularized and can actually heal. And so if you take the patient out of sports, allow this to heal, most of these patients don't go on to needing surgery unless they have a second event later.
A sling works pretty good.
Good.
13-year-old, 3 weeks elbow pain after injury. Since we're looking at the medial elbow, is there some fragments there near the epicondyle? Medial epicondyle? No, more distally there, yeah. Negative then. Yeah.
How about going to an MR?
Sure.
Okay, is that okay?
Yeah.
That's what the MR.
Yeah, so okay, we're a little more posterior. Looks like an avulsion injury. Yeah, in the medial.
Here's maybe the ulnar collateral ligament there. See some edema here. Posterior, this is probably the digitorum muscle.
Okay.
And we also see that there's some edema over here on the opposite side as well.
Mm.
So suggesting that this patient may well have had a dislocation.
Okay.
Well, I'm sorry. Could be a dislocation, or what you could have is a valgus injury, where you have a traction injury here, which is involving the bone, since it's a young kid. The bone's going to be the weak link, and an impaction injury here on the lateral side. So this could be a valgus injury. And then if we look here, we can actually see that looks like there's probably a bony avulsion medially here. The ulnar collateral ligament in kids tends to be much stronger than the bone, and probably an impaction injury because we can see there's edema both in the radial head as well as the capitellum over here. And this was a valgus injury. And here, this is an avulsion injury rather than a ulnar collateral ligament tear. Okay, Jason?
All right. So I think at the proximal insertion of the UCL on the medial epicondyle looks irregular and yeah, kind of amorphous there.
Yeah. Yeah, right. So this was on 3/2/2011. Patient had pain. They treated it conservatively. Also maybe a little bone edema over here on the outside. So maybe a valgus mechanism of injury here as well. And the patient came back with a new injury 2 years later, and this is what it looked like.
All right, again, we have a little trabecular injury, lateral epicondyle, and a lot of edema medially, and I think the there's an avulsion off of the sublime tubercle.
Right. And we have some edema here in the lateral epicondyle and basically soft tissue edema all around it here. And now this was another valgus injury, in this case, a full thickness tear at the distal insertion of the ulnar collateral ligament and muscle tears. Okay. Now, one syndrome associated with injury is called the radiocapitellar overload syndrome, which is due to chronic valgus injury with an ulnar collateral ligament tear in this particular patient. Okay, so let's go to here. Natalia, what do you think?
So 20-year-old professional baseball player, rule out UCL tear.
Okay, so this is a T1 weighted image. Here's the medial side. There's the sublime tubercle. We don't really see the ulnar collateral ligament all that well, in large part because that fat pad that we saw before is no longer present on this case. Instead of having bright fat here where we should have a fat pad, we can see that it's low signal intensity on T1 weighted image. If we go to the PD fat sat, we see a little bit of edema in the sublime tubercle. I don't see really edema within the ulnar collateral ligament, but again, the fat pad is really not normal here. And then the ulnar collateral ligament, as we said here, is a little bit indistinct. So this is someone who had chronic overuse with edema here due to traction changes. But this is one of the early signs that you can get when you have overload to this medial side, which is loss of the normal fat pad.
So you get granulation and fibrosis.
Yeah.
What is that on the lateral side? Is that a
Here?
yeah, that is that a little ossicle?
I don't think so, John. I think that's just some fat there
Oh, I'm sorry.
deep to the ligament.
That's a T1.
Yeah, this is a T1, right. So, so here we can see a little bit of bone edema, and we can see loss of the fat pad. This is also thought to be, when you see this, and it looks like the ulnar collateral ligament is intact, this is believed to be due to overuse trauma, and it's thought to be a precursor to, if you're symptomatic, to increase the risk of developing an ulnar collateral ligament tear. So this should be an indication to rest the patient to allow this to heal before you go on and get a full thickness tear. So one of the useful things about MR with athletes who have symptoms is try to pick up early injuries that can be treated by rest before they get to irreversible lesions that may require surgery.
Okay, so looking at the medial epicondyle.
Robert, did you ever get your microphone to work?
Is it working now?
It is. Okay, why don't you
All right.
take this case?
Sure.
Good.
All right.
These guys are feeling overworked.
You
They're
gotta-
getting
you gotta take the
overuse
next- you gotta
injuries
take
to
the
their
next,
jobs.
5, right?
Yeah.
Take the rest. Here, looking at the UCL, proximally, it looks a little increased in signal, and there may be some edema in the adjacent.
You see something here, right?
Yeah, exactly.
And then right in through there. Okay, so yeah, I would be concerned. This may be in the bone, not great images here. In which case, I'd be concerned about, this is fat suppressed, so we can't look on these. We'd need to look at the T1. So I think it's really important to get T1 and PD fat set images in the coronal plane. The T1, you want to look for that fat pad, which may be here. We don't know. It could be just suppressed. But this looks like there is some abnormal edema there around the origin of the ulnar collateral ligament. If we go to the axial images, I think this kind of confirms that we have some bone edema here. Sort of worried about a chronic traction injury there, don't you think, Robert?
I do, yeah.
Okay.
Agree.
Yeah, and so this was symptomatic, and then again, this is a humeral stress injury, another high-risk lesion that should be recognized and is an indication for the athlete to rest, to allow it to heal before they go back into athletic activity.
So here, this is a PD fat set.
A stir, actually,
Sure.
midfield system.
Okay. See edema in the sublime tubercle. The ulnar collateral ligament looks intact.
Bit of edema here.
You know,
So this is a stress injury, and this time it's on the excuse me, ulnar side rather than the humeral side. Same risk.
All right. So there is a marrow edema, sublime tubercle, and there's some increased signal within the distal ulnar collateral ligament as well. Is that a small bulge in there?
A lot of bone in
Mhm.
the sublime tubercle, right?
Yeah.
If we go to the
Yeah,
sagittal images,
It's a tug lesion.
yeah, right. And there's, if we go to the sagittal image, we can see there's a lot of edema there. It actually goes into the subchondral bone of the coronoid process there as well. And this was a much bigger sublime tubercle stress reaction. And it's important to pick these up. And this may be the kind of lesions you might even want to give a call to the referring physician, depending on how sophisticated you think they are.
So 17-year-old basal picture with increased elbow pain. So there's edema on the sublime tubercle.
Okay, so we have edema. So this is actually what happens if you don't heed the warning signs.
Mhm.
And let's go, so you can see that there's a line right through here
Mhm.
and edema right through there. And this almost looks like there's fluid there.
Mhm.
So it'd be nice to have a CT or an X-ray, right? And here's what the
Mhm.
X-ray shows.
On avulsion.
Yeah, so this is actually a fracture of the sublime tubercle. And you'd like to really catch this before you get a fracture like this. If you catch this acutely, these heal very well, but they would heal much better if you started treating it before you actually developed a fracture. John, do you have any comments?
I'd put the kid in a cast,
Okay, right.
and it works pretty well. That's not displaced, so it should heal nicely.
Good.
It's a 17-year-old kid, and it's a male. If it was a female, that'd be a little more concerned, but not a male.
Yeah. You,
Yeah.
you think
Males are about 2
female is
3
more
years
compliant
behind.
than a male, right? Okay. Yeah. Okay, Robert.
All right, so we have a minor league pitcher. It looks like there's a little bit of fluid adjacent to the sublime tubercle. Yeah, so I'd be concerned for a UCL injury.
Okay. Here's further images.
Here it looks pretty good. It looks like it's intact.
It's pretty good. So this is actually a subtle version of what's called a T sign here,
Okay.
which indicates a partial tear at the insertion. And a partial tear like this, it kind of depends on who you're dealing with. And generally, especially if they're younger patients, if it's non-displaced like this, these will heal with conservative treatment. the problem with a lot of these that you get into, especially if they're kind of high school or level players, is that, or even some professional players, uh, uh, there's a general concept out there that if you get Tommy John surgery, it increases the speed on your fastball. So they're actually not rare for high school players to come in, even though they're perfectly normal, and request Tommy John surgery, thinking that that will, and their parents are behind this often, thinking that that will increase their fastball to the point where they're more competitive at getting in college scholarship or even getting into pro surgery, pro athletics. So uh, there's a tendency here for a lot of unsophisticated people to want to have surgery for this. Though generally is a little bit controversial, but I think most people would agree that if you have just a minor injury like this with a very subtle T sign, that these are reversible lesions and will heal on their own.
Mhm. A cast works fine for that.
Okay. Jason, are you next?
No,
Oh, okay.
Okay, so is there an ulnar collateral partial tear? Um, so we have a T1. Distally, the distal attachment looks okay. I'm not sure.
Look at this carefully. We blow this up. It looks like this. There's a
Mhm.
little bit of signal there between the ulnar collateral ligament and the cortical bone.
Mhm.
Uh, now,
The proximal attachment doesn't look very good, does it?
yeah, well, remember I said earlier that a lot of these patients, the ligament will be obliqued and you won't get the entire ligament on one image. In fact, if you do it,
Yeah,
the patient's a little bit subluxed a little bit.
again, it's skewed a little bit.
Yeah, so we'd need to look at the next image posteriorly to see whether we see the proximal part or not.
Axials would help, wouldn't it?
And the axials can help too. For the purposes of this discussion, let's assume that the next cut more posteriorly is normal up here, which I remember
Yeah.
being. The issue is what's the significance of this signal intensity here between the tendon and the cortical bone? And this has been debated. Usually in young athletes, you shouldn't have degenerative disease, and therefore this is probably a low-grade partial tear, and the patient should be treated but conservatively, allowing it to heal. And this is a middle-aged individual who has some elbow pain, maybe not due to this, and this is really a degenerative lesion. And there's a study that has kind of looked at this, and it turns out that it's pretty common in cadavers for middle-aged and older individuals to have degenerative separations between the articular cartilage and the bone here and the ulnar collateral ligament. And so this can be a normal finding in middle-aged and older individuals. The other thing is the ulnar collateral ligament tears in middle-aged and older individuals tend not to be very important lesions, and you certainly wouldn't want to operate on one. This ligament is important for overhead throwing athletes, but if you're not a competitive overhead throwing athlete, this ligament is not one of the not of major significance. So you typically will not operate even if you have a full thickness tear in older individuals.
All right, 15-year-old pitcher rule out, UCL tear. So in this 15-year-old, I do see a cleft of fluid interposed between the UCL and the sublime tubercle, so I'd be concerned for it.
So in a 15-year-old, it's not
Yeah.
normal to get, especially if you have fluid going there. So this is a classic T sign, and can be a partial tear. Sometimes you can get edema here in the adjacent muscle, which is typically the digitorum, and this is a classic T sign. So this is a paper from 2019. T sign is abnormal, but it's poorly associated with symptoms, and it's poorly associated with the need for surgery. You can get increased signal thickness in this area. It's due to overuse, but it's non-specific. Typically then if it's just a T sign and it's only a partial tear, it's usually recommended to treat those conservatively, though depending upon the level of the athlete, how significant it is for them. In high-level young athletes, they may go ahead and go on to Tommy John surgery, but most of the time they're treated conservatively at this stage. Natalia.
Mm-hmm. Um,
So this is a low field scan. There's a lot of motion artifact. Here we're posterior,
mhm,
here we're more anterior. Patient has elbow pain.
mhm. Um, so there's like some increased signal on the,
Over here.
yeah, on the
Okay.
medial
So right
aspect,
over there. So what do you think this is?
the ulnar collateral ligament.
Right. So this is a thickened ulnar collateral ligament.
Uh-huh.
It's not normal, compatible with a chronic injury, and then we have an acute full thickness tear at its insertion onto the sublime tubercle.
Mm-hmm.
And here we have fluid extending through the tear out into the soft tissues with a little bit of edema within the digitorum muscle here. So that's a acute tear, and like so many tears that we've talked about throughout the body, normal ligaments, they can tear if you have very high level injury, but most of the time when we see tendon and ligament tears, especially in older individuals, you've got a lot of underlying degenerative disease which weakens it before you actually get the tear. And that's what we're seeing here. This is a tendinotic, thickened, abnormal ligament that then tore.
Depending on what this patient does, depends on whether he needs surgery or not.
Yeah.
But the radial side also has a little problem. It
Yeah.
may be in the joint.
Yeah, I think we have a full thickness cartilage defect here and some subchondral degenerative disease on that capitella.
Yeah, so you have to think twice about doing surgery on somebody like this.
Yeah, and it could be that he might have had a little acute injury here too, if he tore this from trauma. You can see a lot of edema in the subacute tissues as
Yeah.
well, and this could be a little impaction injury as well. Yeah. Okay.
Weekend warrior.
Robert. Robert, are you with us?
Yeah, sorry, I
Oh.
forgot to unmute myself.
Yeah.
So we have medial pain from pitching. Proximal UCL looks like there's some increased signal and maybe some edema in the adjacent muscle.
Okay, so this is on 31005, which you can see right up in that area. Now, this patient had, this is an arthrogram, and if we look at the T1 weighted post, this is what it looks like in that area.
Yeah, it looks like it's intact. I mean,
Okay, I believe this was a minor league baseball pitcher, and this was called an ulnar collateral ligament injury, I think is the term that was used. And they rested him for a few weeks. The pain went away right away. And then the season started, and a few months later, he developed acute pain while pitching, and then came back. This was done somewhere else, and he came back, and this is what his scan looked like after his second injury.
Yeah, now it looks like he's blowing out that distal UCL.
Yeah.
There's a lot of fluid there.
So in reaction, this is probably normal, maybe a little muscle strain here, but we're probably partial voluming the origin here in this particular case. And we certainly see no contrast going into that area. And then he then developed the full thickness distal tear in this location. And then he went on to have surgery. Okay. All right.
Okay, an acute ulnar collateral tear, arthrogram. Distal ulnar collateral ligament looks torn. Doesn't look like it's attached to the sublime tubercle.
Yeah, now this is one of the reasons why I'm not a big fan of arthrography, though a lot of people are, because you can see the tear very nicely here. But now we're in a situation, what's all this stuff out here going into the digitorum muscle?
Hmm.
How about atrophy?
Could be atrophy, but it's bright on the PD fat set on the right. So say that's fluid. Maybe.
Bright on the T1, and it's bright on the PD fat set.
Yeah, so it could be contrast.
Okay. And here, this really looks like it's contrast infiltrating
Mm-hmm.
the muscle. But the other thing this could be would be an acute tear, depending on what grade you do, this would be kind of usually a grade 1 tear of the muscle here with edema extending down, which you can see in between the muscle fibers. So
Two.
the problem is that when you do arthrography, if you get extravasation out into the muscles, it can look just like a hemorrhagic acute tear. And they can be hard to differentiate, though in this particular case, this really looks much more to me like it's an infiltration of contrast. But you have to give a differential in that situation. Whereas if they didn't give contrast, you can always see these tears quite nicely without contrast on a modern scanner. And then if you saw this, you would know definitively that it would be hemorrhage and an acute tear. So that's one of the, and as you guys have probably already seen, we see extravasational contrast all the time with arthrography. Most of the time, it's really not an issue, but there have been a few times where determining whether it's a muscle tear or not can be a little bit of a problem.
That makes it more confusing than helpful, doesn't it, John?
Yeah, I think it can at times. And I personally don't really see the reason for doing arthrography. But some people, I guess, just like the image contrast better with arthrography.
Since the ligament is torn, the capsule is torn. So you inject the dye goes right down the muscle.
Yeah, right.
All right. So is that a tear proximal UCL?
You mean right there?
Yeah,
That really looks more mid-substance to me.
mid-substance, okay.
Yeah, proximal I think would be up here. Distal would be down here. I think this is a mid-substance tear, which is what they found.
So 16-year-old basal picture recurrent elbow pain. Uh, mm,
So they want to know whether there's an MCL tear was the history.
mhm,
I don't quite understand
mhm.
what they meant by ulnar MCL, but they probably meant ulnar collateral ligament tear.
Mhm. like medial, maybe.
Yeah. So
Um,
here's the medial side. There's the lateral side. So what do you see here? Okay, this is 62708. We do see that there's a lot of edema here in sublime tubercle.
uh-huh.
The ulnar collateral ligament itself looks like it's intact here on these two images. So this is a distal insertion. Here's the proximal origin up here. So this looks like a stress reaction of the ligament of the bone there. So that's the anterior band is intact.
Tug lesion.
Yeah, tug lesion. So now the patient came back, and let's see, this is on 62708. So now the patient came back about 14 months later, and they're worried about a stress fracture this time. What do you see now? Let's go back here. Let's go back here. We can see the edema here, very low signal intensity on these PD fat sat images at the origin of the ulnar collateral ligament. So now what do you see that's different now?
It's like increased signal on
Here?
the more proximal.
Yeah, so the bone looks like most of that edema is resolved. Proximally, we now see that there's a proximal tear of the ulnar collateral ligament. Now this is, here we can see posteriorly, here's more anteriorly where it's more intact. And then if we look on the sagittal images, this was on 62708, nice and dark up here mostly. On 2209, wait, did I say this right? Yeah. So that
That
those are
should
wrong.
heal.
Yeah, those are wrong. Well, I'm sorry. No, I guess it's okay. So here we now see this is anterior, this is posteriorly, and now we can see that we have a partial tear of the origin of the ulnar collateral ligament. The anterior is intact, and the tear is a partial tear involving the posterior origin. So
That should heal.
yeah. Now, these are actually pretty common if you look for them in athletes, especially if you work with groups that are sensitive to these. The early symptomatic lesions often may be partial lesions, and as John just said, and as we know, this proximal part of the ulnar collateral ligament is pretty highly vascularized, so it can heal. So this would be a lesion that in most athletes you would allow to heal and take them out of sports activities. Though in more aggressive athletes, I've seen some of these go on to Tommy John procedures, but generally it's they're left to heal.
In the older group, especially in golfers that I've seen, and I've seen my share of them, this area is very difficult to take care of somebody in their 40s or 50s. They don't want surgery and they don't want a shot of cortisone. The cortisone in this area doesn't work at all. I've tried it on the medial side. I mean, on the lateral side, I've been very happy with cortisone. Campbell's just not unhappy either. But so, but on the medial side, it doesn't work worth a darn.
Okay, thank you. Robert.
All right, so we have a 15-year-old baseball pitcher with medial pain. Looks like there's a lot of thickening of that UCL and maybe some edema in the adjacent bone. Something like a stress reaction, partial tear.
Okay, so that's on 12/1/09. And then now the patient came back a couple of years later or a year and a half later. This is what it looked like.
So now there's even more edema in the bone and proximal UCL.
Yeah. So they didn't really allow it to heal. This is really a progressive injury, chronic progressive injury. Okay. Elior.
Okay, so here I'm seeing discontinuity of the distal ulnar collateral ligament. Um, there's also,
Which
is that not the ulnar collateral? Oh, I'm sorry. I'm looking at the lateral side. I'll stick to the medial.
Oh, it's a valgus injury.
Yeah, yeah. So edema in the medial epicondyle, and looking at the ulnar collateral looks like a proximal attachment, maybe tear of the proximal attachment.
So laterally, we see this edema here.
Yeah.
Medially, we see a lot of edema surrounding the proximal ulnar collateral ligament, which might be a little bit thickened. And this actually turned out to be a tear here. Uh, so this is kind of a valgus type injury to the elbow.
And what you have to do is look for osteochondritis dissecans on the lateral side
Right.
eventually.
All right, so looks like there's chronic avulsion of the proximal ulnar collateral ligament, either an avulsion or like a ossicle post-traumatic.
So here we can see a lot of chronic traction injury to the medial epicondyle at the origin of the ulnar collateral ligament. And then we have this ossicle. Now, these mid-substance ossicles are actually fairly common in athletes. In fact, somewhere I saw data that about 15% of Major League Baseball pitchers have ossicles in their ulnar collateral ligament. That these have been described in some reports as being congenital, but I don't know why. Basically, all the congenital lesions would just be in professional baseball pitchers.
Repetitive bleeding.
Yeah, so I agree with John. I think these are partial tears where you get bleeding that goes on to ossification, like we've seen multiple other places within the body. That these intraligamentous ossicles are actually an indication of prior partial tear.
It's pretty rare to see anything like this in children. I don't remember. I've seen thousands of kids,
Yeah,
and
I've
I've
never seen one
never
like
seen
that.
one of those.
Yeah. So who's next?
I just went, so
This one? Okay.
So that's Major League Baseball.
Mhm. What?
MLB is Major League.
Major League Baseball pitcher.
So was like an avulsion fracture.
Well, what this is basically ossification of the ulnar collateral ligament. So this is basically a bigger version of one of these, which I think is due to repetitive trauma and injury to the ulnar collateral ligament. As John said, you get hemorrhage and injury to it, and then this is ossification of the ligament itself.
And it looks to me like this may be a little unstable on the lateral side. It's pretty wide, trochlea, and
Yeah, I think we're
no, I
getting.
mean,
I think
I'm sorry, wrong word. But
the capitellum.
yeah, capitellum, and there's a little space there.
Yeah, I think we're getting kind of posteriorly, and we actually think we're posterior to the articular surface here, which can become very irregular.
Oh, I got it. Okay.
I need to see it in other images and so forth, but I think that just may be the positioning. We're really outside, posterior to the articular cartilage in that case. And then here we can see other multiple ossicles, a lot of chronic traction injury here in this picture. And in this particular case on the PD fat sets, we can see that there's a tear of the origin here. So this is chronic degenerative disease, which has gone on to a tear of the origin, the ulnar collateral ligament. On the sagittal images, we can see it goes all the way across. So it's
Are you still seeing these in the recent times, John? Within the
seeing
last 10 years?
seeing ulnar collateral ligament tears or
And
ossicles.
pictures and so on.
Yes. Yeah. Yeah.
Are the pictures still getting these
Yeah. They're still getting the ulnar collateral ligament
from
tears.
overuse?
Yeah, and ossicles, right? They're still quite common in Major League Baseball pitchers.
Mm.
Yeah. And then here again on a low field scanner, we can see an ossicle there. Maybe it's a traction injury, but I think the vast majority of these are ossicles that develop within partial tears within the ulnar collateral ligament. Okay, why don't we stop here and we'll pick up tomorrow and maybe finish the uh, trauma of the elbow. Okay?
Have a good evening, everybody.
Thanks, John.
See you mañana.
Thank you.